Welcome back to the Band-Aid Man OC, your source for EMT, EMR, and sports medicine education. I'm your man, Eric Johnson, aka the Band-Aid Man. Today we're going to be going over Chapter 30 from the Emergency Care 13th edition textbook, talking about multisystem trauma. Before we get started, this is actually going to be a pretty short video. There's only 27 slides, so we're not going to be spending a whole lot of time talking about this. And understand that the concepts in Chapter 30 are really to benefit the individual EMT in their care of an individual that is presenting with multiple traumatic injuries. Now, today we're going to be talking about multisystem trauma as well as management, but really we're going to be focusing mostly on management. So let's start with some definitions. What is multisystem trauma? Multisystem trauma is actually a definition of a particular patient, and the definition is important here. It's not just semantics. We do need to understand what a multisystem trauma patient is. So what is that? It is one or more injuries that are serious enough to affect more than one body system. So let's make that a little bit easier. We've got a patient with multiple injuries that is clearly affecting more than one body system. Now, these multi-system trauma patients can be very difficult to manage, so we need to be very careful about the way that we go about taking care of them. And we also want to remember that the priority here is transport, not treatment, transport. So here's what we would like to look for. Teamwork, timing, and transport decision are all going to be crucial to the effective management of this individual's injuries. So we really need to focus on the way that we prepare for these calls before they occur, as opposed to taking them as they show up. This does require additional training. So how do we determine if a patient needs to go right away or not? Well, patient severity. So what is the patient severity at? And what are we going to do to mitigate some of those severe aspects of their overall health? Well, when we determine how severe the patient is, we really need to figure out what our system is set up for. Different agencies and different protocols will allow you to prioritize patients based off of severity, as well as the size of the scene and the capabilities of the system itself at that time. So understanding your local protocols is going to be the best aspect of care in this regard, but understanding that these decisions need to be made quickly is really going to differentiate you from the lackluster provider, okay? We also need to determine, is it more appropriate for this patient to go to the hospital by ground ambulance, or would it be more appropriate for us to coordinate for an air rescue? So what can we do to determine severity? Well, we need to look at a couple different components, and we're going to break this down over the next couple of slides. Some things that we can look for, some signs that we can look for specifically will be altered mental status, or a GCS of less than 14. This can indicate that the patient has sustained a head injury, or it could also indicate that there is a lack of perfusion to the brain. The next thing that we're going to be looking at is hypotension, specifically any blood pressure with a systolic that is lower than 90 millimeters of mercury. So a systolic of less than 90 should tell us, hey, our patient is starting to fall into decompensated shock, and we are going to very rapidly have an issue. So like I said, this could indicate shock, it could indicate internal bleeding, it could also indicate external bleeding that we have not identified. And if we are doing our vital signs in the order that they should be done during the secondary survey, then we really shouldn't have missed external bleeding. But it is an opportunity for us to say, if we have missed anything, if there are any articles of clothing that we haven't already taken off or cut off, should we go back and check? And the answer would probably be yes. The next thing that we're going to be looking for is an abnormally slow respiratory rate. And specifically, we're looking for something that's trending lower than 12 breaths per minute based on our adult patients. Obviously, this number will be much higher for our pediatric and infant patients, but you should always utilize your local agency's protocols on what they consider to be appropriate or inappropriate. So for today, we're going to talk about adults, and we're talking about a respiratory rate that is less than 12. And that can indicate a head injury or some type of injury to the brain directly, and it can also indicate later stages of shock. Another thing that we want to consider is, can this be attributed to an issue with the airway itself. So do we have an occlusion? Do we have something that is starting to close that airway off? Moving forward, we're looking at penetrating injuries. So now we're moving away from the symptoms that our patient would necessarily complain of, and now we're getting into actual injury types. So one thing that we want to note is anytime we have a penetrating injury, and it doesn't matter if it's penetrating because of a bullet or a knife or whatever, as long as it's more than a simple wound, and we're not talking about a bee sting necessarily, we're talking more about multiple bee stings, like 100 bee stings, and with their penetrating injuries to these areas. So what areas are we concerned about? Super easy. Everything that is above the knees or the elbows. Anything below the knees and the elbows, so the lower aspects of our extremities, whether that be the forearms or the lower aspects of our legs, our hands and feet. Everything else besides that, that's considered a very severe indication for trauma. Another thing we want to be looking for is chest wall instability or deformity, and the instability or deformity of the pelvic bones and the hips. So doing that barrel hoop that we've talked about, where you're pushing inward and then placing your hands directly on top of the sternal plate, or with the hips on top of the pelvic bone, pushing downward. As long as that's all good, we can rule that out pretty quickly. Also, 2 or more proximal long bone injuries, and I will say this, proximal long bone fractures will probably indicate that there was significant injury or significant mechanism of injury. We also want to take into consideration anything where we have where we have 2 or more broken long bones in general. So that could be the entirety of the arm, where we have the radius and the humerus, or in the leg where we have the femur and the tibia. Those are going to be bones that we really want to focus on because of the innervation and vasculature that runs through it. It'll be extremely painful. That's why I bring up innervation. And then the vasculature is obviously important because we have arterial bleeding that could be occurring under the skin. Other injuries, anything that is crushed, degloved, mangled, or pulseless in the extremities. Any areas that are crushed, degloved, mangled, or pulseless need to be noted immediately, and that patient should be off scene very quickly. Also, amputations that are proximal to the ankle or wrist. These are obviously amputations that will significantly alter this individual's life. So we really want to try to find that amputated piece, but we don't want to delay their transport to the hospital while we look. As we said before, pelvic fractures, we're looking for pelvic stability. Anytime that we encounter an open or depressed skull fracture, and any new onset of paralysis. And remember, new onset of paralysis needs to be identified. It can't be, well, I'm a little fuzzy on this side because of a stroke I had 5 years ago and it feels a little fuzzier now. We'll take note of that, but I'm more concerned about the person that was walking and talking and everything was fine and now they can't walk. Other indications, falls of a great height. Depending on where you work, that could be anywhere from 5 feet to 10 to 20 feet. It really does differ based off of county, state, and all of their protocols on how you determine severity of trauma. Also, we get into significant mechanisms of injury, such as gross intrusion. Gross intrusion being that anything outside of the car should not be making its way inside of the car. Vehicles are designed, especially newer model vehicles, are designed to crumple before they invade occupied space. So where we work locally, that number stands at 12 inches, 12 feet, that'd be crazy, 12 inches into an occupied area, or 18 inches into an unoccupied area. So if it's greater than a foot in any space that someone was sitting, that's considered a significant trauma mechanism. Or if it's greater than a foot and a half in any area that was not occupied. Also, ejection from an automobile, or death in the same passenger compartment of that automobile. We really need to look at these things saying, hey, if it was bad enough to cause you to exit your vehicle forcibly or to kill somebody in the vehicle, there was probably significant amounts of trauma that was exerted on that person. We can also use vehicle telemetry data, but we may not have access to it. So really, our vehicle data that we're going to be looking at is what does the vehicle look like compared to a non-crashed version of that car. Now, I'm not telling you that you need to memorize what every single vehicle looks like in the world, but you can take a look at a vehicle and you can say, oh, that looks like there was a pretty significant amount of force behind it. We can also talk to other people, bystanders, the drivers of both vehicles, and ask, approximations of how fast they were traveling. But, you're probably not going to get a very accurate answer because for bystanders, everything seems much faster. They're either in a non-moving vehicle or they're moving in the opposite direction, so it tends to look faster. And then for the people that are in the vehicle, they are not typically paying attention to how fast they're going because they're so concerned about the impending impact. So take those with a grain of salt and always get good photographic evidence of what you see on scene. Normally, I would say don't ever take pictures, but we have so many options for documenting what we're doing. Most of the agencies out there are using either a tablet device or an iPad to do all of their patient care reporting, and they are looking at different angles of the vehicle to see if there's something that we missed, and that's where we're taking lots of pictures. Moving forward, when we're determining severity, we do have special patient groups and special considerations. So let's talk about some of these things. First and foremost, older adults do not efficiently compensate for shock. As we learned the other day, after the age of 30, we lose about 1% of the function of our organs every year. Children, on the other hand, are not going to efficiently compensate for shock if left unmitigated. And as we've talked about in our pediatric chapters, we already know that pediatric patients will do okay, and they'll do okay, and they'll do okay, and then they'll fall off a cliff, and their blood pressure will tank, and their respiratory rate will tank, and their pulse will go absent. And these patients are much more susceptible to compensatory mechanisms that will cut off at the same time. It's not like going through a period of low water pressure where you're not getting as much out of the shower head or out of the sink as you would have liked. It's when the water is completely shut off and you're stuck there with shampoo in your hair and you're really mad because you've got something important to do. Understanding the differences between the compensatory mechanisms between pediatric patients and adult patients, especially our geriatric patients, will help us remember that these are special groups. So really, peds, old folks, geriatric patients, peds and geriatric patients are going to be our most susceptible groups to trauma, although our most common trauma patient is in the male from 18 to 30 group. Okay, moving forward, children may benefit from transport to a pediatric specialty facility if that's available. Here where we work, we do have a pediatric specialty hospital that also doubles as a pediatric trauma receiving center. So we do have the ability to take those pediatric patients to those facilities, but we don't want to delay their transport to that specific facility unless it makes more sense to go there than a standalone adult trauma center. Typically, trauma centers are set up to take all ages, whether they be neonate all the way through geriatrics, and we want to really focus on time on scene and time from the injury till they get definitive care. So we want to really get them going as quickly as possible. And then finally, we have patients that have certain conditions, whether they be medical conditions that will not allow them to clot properly. They've got some type of anemia, or they're taking a medication that does not allow them to clot properly, which would be an anticoagulant like warfarin or Xarelto or any of those brand names that we've talked about time and time again. And then finally, we have our pregnant patients. Pregnant patients are always going to be a special consideration because we have two individual patients that we need to think about. If the pregnant woman is greater than 20 weeks pregnant, we really do want to consider fetal distress and fetal injury when we're looking at trauma. If it's less than 20 weeks, it's something that we'll still know. They are still pregnant, but because the cutoff for a viable pregnancy, surviving that pregnancy, is 20 weeks, we generally will make a note of them being pregnant, but they will most likely be treated as a single patient once they get to the hospital. We'll still have that mental aspect of, well, it could be two patients. And this doesn't happen very often, but I have had patients that have been very upset about the accident that they were just in, and they forgot exactly how pregnant they were. And I just consider, if you've told me that you're pregnant, you're pregnant. But I do want to make that quick note about the 20-week line. Next, management. How do we manage these multi-system trauma patients? Well, it's pretty easy. Practice makes perfect. We need to understand what we're doing before we go out into the field, and that's why training is so extensive. The average training period for a brand new EMT at a new service is anywhere from a week to 2 weeks, and for some of the bigger services, it can be greater than a month. And you're almost always on some type of a shift with a senior EMT or senior paramedic so that they can observe you for the time that you are on probation. And a typical probation is anywhere from 90 to 180 days, so 3 to 6 months. If you do have a job as an EMT working for a fire department or perhaps for a public safety department, that may be much longer, and your training may be much longer as well. But these are generalized numbers, so we do have a better idea of what's going on. Moving away from that pre-training, we need to start determining what we're doing when we go on scene. And that's when we start looking at our MDT, the computer that's in our ambulance, and saying, okay, well, these are the pieces of information that we have. When we get on scene, I'll go ahead and I'll start interviewing the patient. Can you do me a favor? Can you get a quick set of vitals? Can you do this? Can you do that? And then determine that with your partner so that we can all be doing something that is for the betterment of the patient. As we're reviewing these roles, it's important to understand that diplomacy will go a long way, and we can really get a better response to the call if we acknowledge that everyone is important. So I'm not trying to say you need to handhold and kumbaya with everybody, but if you say, all right, so I'm going to go ahead and I'm going to check the patient, and I don't know, you can just do whatever. That's a little dismissive, so just take a moment to acknowledge the fact that their job is important, not by saying your job is important and holding their hand, but more of putting the importance on it. I'm going to go ahead and I'm going to start doing my assessment of the patient. If you could do me a favor, please, and begin getting a set of vitals. And if you see any other bystanders, if we could start interviewing them as well, that would be great once you're done with the vital signs. That'll be a huge help. Boom. You just made everyone feel like they are part of the response and part of the team. Next, we need to ensure scene safety. Now, this is not something that I'm going to go into too much detail on, especially because we're going to be doing videos on operations. But, make sure that your scene is safe as you approach, and then look for scene safety indicators throughout the call. If the scene is becoming unsecured or unsafe, then it's time to move. Moving forward, perform your primary assessment, get those ABCs knocked out, ensure that the airway is open. Perform any urgent or emergency moves, and we've talked about the difference between those before, so I won't go into that again. And start to determine what's going to be the best way to transport them, whether it be ground or air. Also, we want to give a report to the trauma center as soon as we do our handover, and if this is going to be an extended on-scene time due to vehicle entrapment or transport complications, whatever the case may be, we may want to consider making very early contact to the trauma center so that they can get their team ready. That is the most important concept between us and the hospital, is us giving them enough information so that they can prepare. They don't do the same prep for every trauma patient. Depending on what's coming in, they may need to bring in more specialists. And they also want to advise other parts of the hospital, because an emergency department is simply part of a larger hospital system. We do have priority, and when I say we, I mean we as EMTs and emergency personnel. We have priority for things like the CAT scanner or MRIs or X-rays, whatever the case may be, but we do need to acknowledge and accept that we are using a component of the hospital that's used by other floors. So the earlier that we can give them a heads up, the better they can prepare. Also, giving them an accurate ETA is super important. We don't ever want to undercut ourselves. So if you are thinking you're going to be there in 10 minutes, it may be better to say 12 to 15 minutes. Showing up too early is a problem. So make sure that we do that. Some other considerations. When we are determining the best transport, we need to determine things like traffic flow, time of day, weather, scene safety, whatever the case may be, and of course the patient's condition. If we've ordered an airship and the weather changes rapidly and it's no longer a viable option for us to expect an airship to land where we are, we may need to change the LZ. So we may need to drive our patient to a different location to be picked up by helicopter, or we may need to bypass air transport and go by ground, so transport with our ambulance. Also, take into consideration how long it's going to take to A, get to your patient, and B, start transport by ground. If it's going to take more than 15 to 30 minutes, it may be a good time for us to go ahead and call in for an airship and get them in the air. We may not ultimately use them, and depending on where you are, they may have very specific protocols on how and when to call in for an airship. But if we're going to use them, we want them in the air as quickly as possible. They have to do pre-flight checks. It takes them a little bit of time to get everything spun up, and then they have to actually fly to us, observe the area, find a safe landing zone, and then land, and then power down. We don't, at least here, unless we are doing some type of a rescue, we do not do what's known as hot loading, where we load the patient into the air ambulance, into the helicopter with the rotors still turning. Also, make sure that you understand that the location itself, while it may seem reasonable to you, as soon as that airship gets on scene and they take a look, if they tell you, hey, we can't land here, that's it. You can't argue with them. You need to let them know, all right, well, thank you very much. If you see another suitable LZ in the area, go ahead and let us know and we can meet you there. But if not, we'll just have to ground them. And that is ultimately the determination of the pilot of the airship. There is no one else that can override the individual pilot's decision to land or not to land. Moving forward. As we're going through our call, we need to make sure that we follow our priorities that are based on assessments. We can't look at the patient and go, oh man, they look really bad. They've got blood all over. We don't know anything. We need to do an assessment before we start making orders. We also want to make sure that we don't delay transport if we're going to try to perform some type of a treatment. Unless that treatment is to open their airway, fix some type of an issue with their breathing, or fix some type of circulatory issue, especially with bleeding, then we are going to focus on doing a quick head to toe and getting them into the ambulance. We can do treatments on the way to the hospital. We also want to make sure that we are showing good judgment. If it's just us and our partner, we can postpone taking vital signs until we're en route or when it's most appropriate. But if we have a more robust response where we have 4 firefighters or multiple public safety agencies responding, then we can go ahead and we can delegate that. And remember, if we are running as a BLS crew, once ALS arrives on scene, they're going to go ahead and take over the call. Then they can start delegating out as well. Again, these bits of information help give the hospital staff time to prepare both their own response, their own equipment and staff, and they are better prepared for you as you come through. The question now is, what type of treatment should we be actually providing on scene for life-saving interventions? Well, aside from the assessment of the airway, breathing, and circulation, we can do specific items such as stabilization of the cervical spine, airway suctioning, insertion of an oral or nasal airway such as an OPA or NPA. We can restore the patient's airway. We can ventilate with a bag valve mask. We can administer high concentrated O2 via non-rebreather mask. We can control bleeding, and finally, we can completely immobilize our patient. And there are other things that we can do on scene, but remember, if it's not going to kill your patient, it probably doesn't need to be done on scene. It can probably be done on the way to the hospital. Now, trauma scoring systems are a bit different. It's not just looking at the patient and saying, aha, I see broken bones and blood and things that are supposed to be outside of the patient inside of them. therefore they are a trauma. Ta-da. This is more of a trauma based on numbers. It really is trauma based on numbers. It's a numerical rating system to determine how severe a patient is. Some systems really lean on this so that they can use their own internal set of protocols so that they can get everything ready to go before the trauma patient shows up. Where we are locally, we have an abundance of trauma centers. We have 3 that are general purpose, one for pediatrics specifically, and then we have another that's just outside of our county that can accept patients from here. And they're all fairly centrally located. And we don't utilize any kind of a scoring or numeric system to determine how severe a patient is. We just have trauma protocol. If the patient meets that trauma protocol, or if our provider judgment would determine that they would be better served at a trauma center, we can go there. But back to the trauma scoring system, if you are at an agency or in an area that utilizes these, it helps do a couple of things. It assigns a number to your patient, very similar to a GCS score. It helps describe severity with objectivity. It also helps determine if that patient would be better served going to a trauma hospital or if they would be better served going to a local hospital, stabilized, and then possibly transferred. And it also helps trauma centers evaluate the care of patients in similar situations. So this is kind of like QA/QI. This is a way for us to do better in the future. The most common trauma scoring system is the Revised Trauma Score, or RTS. It is made up of the following components: the Glasgow Coma Scale, or GCS, their systolic blood pressure, and their respiratory rate. So this will give us a generalized idea of how they are mentating, so what their neurological and mental affects are, what their response is. Their systolic blood pressure should give us an indication of what their circulatory system is doing, and their respiratory rate should tell us just about where they are at in terms of being able to bring in oxygen and expel waste like carbon dioxide. So it's a pretty all-inclusive numbering system, and it works really well. I will note, there's nothing here about pulse, and I would say that this would be a system that would probably benefit from bringing in the general pulse rate, but I can also, from the opposite side of the fence, see why they excluded it. Having more components typically will lead to there being more confusion and could lead to a strayed number or a patient that was poorly identified as being traumatic when they were not, and vice versa. So whatever your local system uses for trauma scoring, use that. And remember that it's just a number. If your judgment says that this patient is a trauma patient, follow that and then transport them there. But just have that little bit in the back of your mind. Is this a $10,000 bill that my patient needs to have? If you feel that that's correct, then send them. Now, this is a sample of the RTS form, the Revised Trauma Scale, and you can see, or I'm sorry, the Revised Trauma Score, and you can see it's pretty basic. Based on general GCS score, 13 to 15 gets 4 points, 9 to 12, down to 3, 6 to 8, down to 2, and then anything lower than that is 1 and 0. Same thing with the systolic blood pressure and the respiratory rate. And because this is a scoring system that is very simple in terms of score, but it has a lot of different numbers, I would probably recommend utilizing some type of a printed version of this when you go on scene, unless you're really, really pretty confident that you know what you're doing. Also, as a quick added aside, most EPCR programs will do this automatically if you have it enabled. So just something to note. Now, we've gotten to the point where we're going to do the chapter review, but before we get into that, I just want to make a quick note. Multisystem trauma, as it stands for the textbook and as it stands for what we do, stands to give you a very complicated patient. They're not complicated because they are, spawning a third arm or, attacking you or anything like that. It's because it's difficult at times to determine what injury will kill them faster. So this is when teamwork really comes into play. If we have a patient that has an airway that's compromised and they're bleeding significantly, those are two problems that don't cancel each other out. We have to address both. And the question is, especially if you're alone, what do I focus on first? It is truly the dichotomy of I want to fix this, but if I don't fix the other thing, then they'll die. It's a catch-22. You can't win. So this is where good communication and good teamwork will benefit you. And unless you're working in a very rural area or on a very special assignment, you're not going to be responding to these calls alone. This is where delegation becomes a key skill. And delegation, don't get it twisted. Delegation is your ability to say, there are multiple jobs that need to be done, and I will simply assign them because of the lack of anyone else doing it, or because that's my job, because I'm the senior EMT, or because I'm the paramedic, or because it is my call to run. Okay? Now, back off my soapbox, let's do our chapter review. Multisystem trauma is a serious condition in which two or more major body systems are injured or affected. The revised trauma score is one method of classifying trauma patients by severity and includes the GCS, systolic blood pressure, and their respiratory rate. Remember, your primary assessment should determine whether your patient is seriously injured or potentially seriously injured. And we also want to utilize the components that we've learned today to determine how severely they are injured, because there are different grades. We also want to remember to limit our scene treatment to only focusing on life-threatening conditions. We also want to remember that patient severity based on psychologic criteria, anatomic criteria, mechanism of injury, so on and so forth, should be used to decide whether transport to a trauma center or local hospital is more appropriate. And remembering as well that everywhere that we go, there will be a different set of standards on how to accomplish this. Some questions to consider as you're doing your patient assessment. Is my patient seriously injured or potentially seriously injured? What kind of intervention should be performed on scene versus en route to the hospital? What is the most appropriate transport method for my particular patient? And finally, what is the most appropriate transport destination for my patient based on what I've found? Now, the next two slides are going to be a quick opportunity for you to test these skills. Go ahead and comment below so that I can take a look and tell you how you're doing, and I'll go ahead and comment right back. So here's your case. You have a patient that was involved in a car crash with significant intrusion in the area where they were sitting. The patient is alert and complains of pain in their ribs. They have a pulse of 96 and regular. Their respirations are 30 and shallow. Their blood pressure is 100/62. Pupils are equal and reactive. Skin is cool and dry. Your partner comes up and says the patient is stable and can be easily transported to the community hospital nearby. You, however, think the patient should be transported to the trauma center. How do you justify your decision to your partner? Now, for this scenario, whether or not you think this patient is a trauma patient, what pieces of information can you pull from to determine if they are truly a trauma patient, and how would you do that? That is our very last slide. I want to say thank you to everybody that was able to watch this fairly brief video, for my channel at least, and I want to encourage you to like and subscribe, and be sure to share this with anybody else that you are going to school with if you're not in my program. And of course, if you are in my program, be sure to watch this so that you can get a little bit of extra insight before you take that big old national registry test. Thank you very much for stopping by, everybody. Have a great one. Goodbye.